If I'd known you were going to say all those nice things. Actually, I'm going to show you two videos. Ray and I took a video of the hysteroscopy setup that I use in my office, and tried to put in the points that we think are important in that video. So I don't know if you can hear this or not. Okay, we're going to talk about outpatient or office hysteroscopy. And I suppose the first thing to say is that this procedure really should be less uncomfortable, and is less uncomfortable in practice, than a colposcopic examination, and perhaps even taking a smear. And the reason that it's so relatively comfortable is that you don't use a speculum. And also because you don't use a forceps to grasp the cervix. So it's speculum free and it's grasper free, gentle passage of a 4mm rigid scope into the uterine cavity. To try and ensure that it is always comfortable, you need to have certain criteria in terms of case selection. It's certainly possible to do it with nulliparous postmenopausal women, but it's a good bit more difficult. And some postmenopausal women, their cervical canals will be so tight that they'll either need a little bit of local or a little bit of cervical dilatation. And it's not always possible to do it in the office. You sometimes do need a general anaesthetic. But I would say that in 90% of the cases, you can do diagnostic hysteroscopy in the office on postmenopausal women. Premenopausally, it's virtually everybody can accommodate a diagnostic hysteroscope. So that's case selection. The environment in which you do this procedure is hugely important. If you bring somebody into theatre with a theatre gown on, with loads of equipment around the place and theatre lights, it's intimidating, it's anxiety producing, and it'll be hard to get your patient sufficiently relaxed on a routine basis. So therefore I think the office or the outpatient room is a very much better environment than theatre. Secondly, as with the vocal local principle in colposcopy and LETS, having a good nurse to accompany the patient and to talk the patient through the procedure, or just to be there and to hold her hand, I think is really, really important. But I think it is right that you downplay the procedure to the patient, that you're just going to have a look inside their uterus. You don't have to exaggerate the difficulty of the procedure, because it ain't difficult. And you don't have to emphasize that other people do this procedure under general anesthesia and you're doing it under local, because they're all wrong and you're right. So I think that downgrading the procedure to its proper place in terms of intervention and discomfort is really important. So we ensure that the patients have a nice private place to get changed. They then come in here, they sit in a regular gynae couch. You may or may not want to do other procedures at the same time, for example, take a smear or something like that. But then, and if you're not taking a smear, you don't need to use a speculum at all. Okay, in terms of the principles of this procedure and the reason that it's comfortable and easy, there are a number of things that you have to bear in mind. The first one is that you don't use a speculum. You put your index finger or your middle finger into the vagina and you touch the cervix. Once you've touched the cervical os, you slide the hysteroscope next to your finger, and once you then visualize the ectocervical, the cervical os, then you gently traverse the endocervical canal whilst passing saline. The reason we use saline instead of CO2 is that CO2 occasionally annoys the diaphragm after it's passed through the tubes. Saline's a little bit more messy, but doesn't hurt at all, doesn't produce any discomfort. You can either use a single litre saline for an entire clinic of 4 or 5 patients, or you can use a little bag of saline. It's personal preference. If you learn hysteroscopy in patients under general anaesthesia, you'll sometimes see that people grasp the cervix, dilate the cervix, and then pass the hysteroscope. They put the hysteroscope in the uterus and then start looking. That is often associated with some bleeding. It's maybe necessary to dilate the cervix sometimes because the hysteroscope is so big, and all of that means that it's uncomfortable. With outpatient or office diagnostic hysteroscopy, you're using a hysteroscope that's sufficiently narrow that you don't have to distend or dilate the cervix. By doing it under vision, you watch the hysteroscope pass through the endocervical canal so that you don't touch the side walls of the endocervical canal, and you don't push the tip of the hysteroscope into the side wall of the endocervical canal, and therefore you don't produce discomfort. You use the saline to gently flow just ahead of the hysteroscope, but you pass the hysteroscope through the endocervical canal without touching the side walls sufficiently that you cause bleeding. So this is a no bleeding technique, and I'm sure that not touching the endocervical walls is one of the reasons that it's so comfortable. Technology is great. That probably is the end of that, I think. Okay, I'm going to show you another video of a slightly different technique of doing hysteroscopy. But just before I do, I just wanted to talk through this method. The other method is where you do a vaginoscopy and you put saline into the vagina and find the cervix. You don't use a finger, and we'll show that in a moment. One of the criticisms of this technique is that you might introduce infection by traversing the vagina with a hysteroscope. I think if you use a sterile glove, the hysteroscope hardly touches the vaginal walls. It touches your glove. I haven't seen endometritis after office hysteroscopy, and I've done about 1,000 cases of it. But that's a possible criticism that you may wish to think about. One of the other advantages of saying this is that it's almost impossible to perforate the uterus in the office, because the patient will tell you that you're doing it whilst you do it. Whereas under general anesthesia, you've all seen somebody perforate the uterus. And that's because the patient ain't going to tell you, because she's asleep. So uterine perforation just simply doesn't happen in the office. I would say it's literally 1% of people who would find office hysteroscopy uncomfortable, sufficiently uncomfortable that they would want some kind of analgesia. I used to do hysteroscopy in the same way as under general anesthesia, whereby I grasp the cervix and I put local in the cervix. And it's all completely unnecessary. It really, really, really is. And it's far preferable not to use a speculum, I think. Jean-Luc and I have been running hysteroscopy courses around Europe for many, many years. And we moved to flexible hysteroscopy about a decade ago. I don't use flexible hysteroscopes in the office because they're expensive, they're difficult to sterilize, and to be perfectly honest, the 4mm or less rigid hysteroscope is very easy to use. And if you watch yourself walk in with it, you really will find it very, very easy to do. And I don't know why it hasn't taken off in Ireland. I simply don't know why office hysteroscopy is relatively uncommon. I think it's because most of us were obstetricians and not gynecologists. And office gynecology isn't remunerated very appropriately. And so to set up an office hysteroscopy service seems to be more difficult and more challenging for some units. But in an individual office, in your own office practice, once you've purchased the gear, really there's virtually no expense in providing the service. And VHI do cover it in your office. So the other video I wanted to show you is Circus. Is Circus one on this, right?
This video aims to demonstrate the common procedure of hysteroscopy. This video aims to demonstrate the common procedure of hysteroscopy using a cheap, reproducible uterine model and the vaginoscopic approach. Hysteroscopy is a form of endoscopy that can be used to visualise the uterine cavity, the endometrium, the tubal ostia, the endocervical canal, the cervix and the vagina. It can be performed easily in the operating theatre under general anaesthetic, or more commonly in the office or outpatient department with or without the use of local anaesthetic. Hysteroscopy is commonly used to investigate irregular bleeding patterns, menorrhagia, pelvic pain, infertility, and Mullerian or anatomical abnormalities. It can also be used to remove polyps, fibroids, uterine septum, or sample the endometrium, or remove foreign bodies such as marina coil. The hysteroscope is an endoscopic camera which allows visualization of the uterine cavity. It is composed of optical and light channels or fibres. It consists of an outer sheath or metal tube which surrounds channels for the telescope, distending media inflow and outflow, and operative instruments. Illumination is provided by a light source which is connected to the hysteroscope by a fibre optic cable. Distension media employed can be gaseous or fluid in nature, for example glycine. The patient should be positioned in the dorsal lithotomy position. They should be sterilised with povidone iodine or chlorhexidine and draped with surgical drape. The hysteroscope is assembled by inserting the scope into the outer sheath. The integrated locking system is employed to ensure that the scope and the sheath are securely attached. The distension media is provided by a tubing system attached to the inflow channel, and the camera is attached to the end of the scope, which in turn is attached to the visualization system or stack. The light source is attached to the scope, and the pressure behind the distension media should be set halfway between the patient's systolic and diastolic blood pressure. Bimanual examination of the patient should be performed to assess the position of the uterus, whether it is retroverted or anteverted, mobility of the uterus, and the size of the uterus. In the vaginoscopic approach, a tenaculum or speculum is not employed. The labia minora can be closed manually to allow retention of the distension medium. The cervix can be visualised with the hysteroscope, and the hysteroscope can be directed into the external os of the cervix, into the endocervical canal, and advanced slowly into the uterine cavity. Alternatively, the index finger can be inserted into the vagina to identify the cervix and the cervical os. Using the index finger, the hysteroscope can be introduced via the external os of the cervix into the endocervical canal, and while watching the visualization system, the hysteroscope can be advanced slowly into the uterine cavity. Here we have produced a cheap, reproducible uterine model using children's modelling clay and straws to mimic the tubal ostia. The hysteroscope is inserted into the external os and advanced slowly into the uterine cavity. Once in the uterine cavity, we can assess the endometrium, and by rotating the light source to the left and to the right, we can visualize the tubal ostia. Here we have recreated a fundal polyp. The endometrium and the endocervical canal should also be assessed while the hysteroscope is being slowly withdrawn. In summary, during this short video, we have successfully demonstrated, using a cheap, reproducible uterine model, the vaginoscopic approach to hysteroscopy.